respected chairperson, senior faculty, my colleagues, friends, and Dr. Jayakishan, thank you for this wonderful opportunity. What I'll be talking in the next 20 minutes or so will be on the impact of childbearing on pelvic floor. Actually, my previous speakers have made this topic very simple. This has something to do with why. I'm trying to answer why these women had to undergo such surgeries. So we need to understand the basics of anatomy, why it matters, how childbirth affects pelvic floor, and what is the role of we the obstetricians to prevent women from reaching a stage of pelvic organ prolapse. Okay. Now, this is just a brief review. Let's go start with the basics, the brief review of the pelvic floor. We have seen the surgery, so I don't have to go into the details. We know that the pelvic floor comprises of the dome-shaped muscles and fascia surrounding urethra, vagina, and the anus. Not only that, you have the ligaments and muscles, and we have seen that in the absence of a proper support of pelvic floor, how the continence, maturation, defecation, and other sexual functions is being affected. Okay. This we know this, how the continence and the other thing is supported and kept by the pelvic floor muscles. We know that the main muscles are levator and the coccygeus muscles, and this is formed by, there are a group of three muscles, puborectalis, pubococcygeus, and the iliococcygeus muscle. And these are the basic anatomy, and also remember that endopelvic fascia is also important, not just the muscle alone, the fascia. We all know this DLAMS is 3 levels of support. The level 1, level 2, level 3, for lack of time I am not going into that. And most important point is the hiatus in this diaphragm, pelvic muscle. And of the three, we have the 3 pair of muscles and we have the 3 hiatus. The through is the urethra, vagina, and the rectum pass. And out of this, the most important is the genital hiatus. It's because of this problem we had to see all the pelvic surgeries. Now, I think most of you might have seen this video. This video is taken from the Continence Foundation of Australia that shows how the pelvic floor muscle is important for maintaining the continence. We know that the vagina, the urethra, and the anal opening. Actually, this is how when you do the Kegels exercise, it helps. Now, in fact, thanks to the newer ultrasound imaging modalities, the importance of pelvic floor is not only restricted to the pelvic floor support. Now we know that with the newer we found newer understanding of anatomy. A lot of interest is being shown in the anatomy, particularly the relation of the pelvic floor with other structures. We know that the pelvic floor has this one respiration, and also it has relationship with maintaining the posture, the maintaining the upper, lower extremity, everything has been connected because of the connection with the endopelvic fascia, which is the new information that I got when I went through referring this. Now, of course, the configuration of pelvis is also important. Now, the most important question is, why this health of this pelvic floor matters? Why should we bother about it? We know that mostly when we are taught about the antenatal care, the end of the antenatal care, what is the aim of the antenatal care? Is the birth of a healthy baby and a healthy mother. But now, it has gone beyond that. We know that previously we have been concentrating on reducing maternal mortality, morbidity. Now, the focus is on improving the quality of women's health. Women demands that. If you listen to the symposium that has been, that Dr. Umaram, all the situations she has put forward, basically that is on how women are bothered about the quality of life. This is because the study shows that the perineal trauma, to whatever reason, and the commonest reason is childbirth. They found, the newer studies have found that 91% of nulliparous women and 70% of multiparous women, they suffer from perineal trauma during delivery, and this has potentially significant impact on daily activities, psychological well-being, sexual function, and overall quality of life. Previously, most of the women were suffering in silence, either because of ignorance or because of taboo or shame. But times are changing. The young generations of gynecologists and obstetricians will have to also adapt to the new changing attitudes of the public and understand that it's our responsibility to ensure quality of care. Now, this is a study that is published in 2023. This is about the pelvic floor dysfunction, the prevalence and associated factors, and they found that 1 in 4 adult women suffer from pelvic floor disorders. Now, we all know this. The various things that comes under pelvic floor disorders are the urinary fecal incontinence, pelvic organ prolapse. Now they have added other things also, even chronic pelvic pain, dyspareunia, puberectalis syndrome, vulvodynia, all this has been included as part of pelvic floor, and all that is bearing on our obstetric practice. Now, suppose someone comes and asks you, Doctor, you didn't attend my delivery properly, that's why I have this problem. Can we accept that? Can we put all the blame on childbirth? No. Actually, in 2008, this all pelvic floor disorders is considered a chronic disease. Like any other chronic disease, Delancey has come out with it as a natural history. If you look at the natural history of the pelvic floor, a lifespan approach where it's divided into 3 phases. The phase 1 is the predisposing factors. That is the growth and strength of the initial strength of muscle as the child develops into adolescent, then adult. Second is the inciting factors. And then the inciting factors will lead to the intervening factors. Estrogen reduces, the muscle strength comes down, and she will go in for pelvic organ prolapse. So I will be concentrating mainly only on the phase 2. That's my topic, is on the inciting factors for pelvic floor disorders. We all teach our students and we learn about the 3 P's of labor: passenger, passage, and power. But little we teach our students and we give importance to the secondary powers, the abdominal muscles and the pelvic floor. We know that the phase of childbearing, pregnancy has got some impact on the levy training because of hormonal changes and also the mechanical effects during pregnancy. Now, what's our responsibility? How can we prevent that? Preventing pelvic floor disorders is gaining a lot of attention, and when women come to the individual mothers come for checkup, we prescribe them iron, folic acid, we find out whether they fall under high-risk group. But we have an important responsibility also to prepare the pelvic floor for childbirth. That includes so many things, the diaphragmatic breathing and other things. I am not going into details of that. And we teach them on the mechanism of labor, cardinal movements of labor. Now people are talking about the physics of childbirth. That means the impact of the baby as the baby stretches the descends and stretches the perineum, what it does to the pelvic floor. Now, this review that has been found in 2023, the study clearly found that pelvic injury during vaginal birth is life-altering and is preventable. Now, if any postgraduates are there, can I ask a question? What's the commonest cause for a pelvic organ prolapse? Normally people answer it's multiparity, right? Now the new study that's published in the International Urogynecology 2019, it says that it's the first birth that is most important. First birth causes the maximum damage and the subsequent births add to it. Now let's see some of the common practices that we carry out in labor. First is perineal massage. How many of us practice that? It's a very simple procedure which can be done after 35 weeks of gestation and during delivery. This has been proved that the studies that's reviewed in 2023 February says that massage during the second stage of labor appears to be effective in preventing episiotomies and reducing the duration of second stage of labor. Just remember the case that is presented by Dr. Maran, woman refusing episiotomy. Now they may ask you, doctor, how can I protect my pelvic floor? We need to change our attitude and help them. We have to go by what they tell you to do. Now, what about episiotomy? I'm not going to talk about whether episiotomy is indicated or not. But what is the angle at which you cut the episiotomy? All the textbooks talk about 45 degrees. But now, recent study says that it's at the stage of maximal stretching. The anal spindle is distanced to 2 to 2.5 times its normal position. So you need to start in the faucety and the angle has to be 60 degrees. But I have also seen some studies that's challenging this question. But they found that episiotomy that is done at the 60 degree has found to reduce the anal sphincter injuries. Now, delivery of head. This modified residence maneuver that has been described in many books, but look at the studies. They found that residence maneuver during labor is not protective for severe perineal laceration, that is 3rd and 4th degree perineal lacerations, and it's also associated with higher postpartum pain. Now, this is a very simple technique, bomb perineal compresses. This is application of compress. This is already discussed, so I'm not going into the details of that. Maternal pushing. There are two types of pushing. That's a common word, and we all hear in the labor means push, muku, muku, muku. But when should she start muking? There are two types. One is a directed and second is spontaneous pushing. That is wait for the mother urge to push. That is the thing that protects the pelvis and the perineum. Now, perineal support. This is also has to be practiced nicely because it has to be a bimanual. One hand protecting the head and helping in delivering slowly. The other dominant hand protect the perineum, and that has to be continued till she delivers a shoulder. Now, what is this? What is this? Fundal pressure. This is one thing you see in the labor room. Try to push. And we'll go through a study that tells you the fundal pressure in the second stage labor is not recommended, and this is based on the study.
Fundal pressure during the second stage of labor, described also as the Christeller maneuver, controversial, understudied, and underreported maneuvers in obstetrics. In particular, the effect of the Christeller maneuver on the risk of levator ani avulsion has not been previously assessed. There is an increasing body of evidence suggesting that levator ani avulsion is the main link connecting vaginal birth and pelvic organs prolapse. The aim of the present study was to investigate the association between application of fundal pressure during the second stage of labor and the risk of levator ani muscle injury. This was a prospective case control study. Women were recruited following their first vaginal delivery. Women who underwent the Christeller maneuver were recruited as cases, while women with spontaneous vaginal delivery were recruited as controls. All women were invited to undergo 4D transperineal ultrasound examination 3 to 6 months following delivery. The main outcome measure was the presence of levator ani muscle avulsion on the 4D transperineal ultrasound. Women who underwent the Christeller maneuver had a higher prevalence of levator ani muscle avulsion than controls. On multivariate logistic regression analysis, use of the Christeller maneuver was the only independent factor associated with levator ani muscle avulsion. The Christeller maneuver is associated with an increased risk of levator ani muscle avulsion when applied on women during their first vaginal delivery.
So, the fundal pressure and some of the practices which we have been following is found to be harmful for the pelvic muscle. So, as to quote the word by Princess Nodamba of WHLC Direct General Family Women, a good birth goes beyond having a healthy baby, and the most important thing to conclude, your take-home message should be, women in the second stage of labor, techniques to reduce perineal trauma and facilitate spontaneous birth, like perineal massage, warm compresses, and hands-on guarding in the perineum are recommended. Routine or liberal use of episiotomy is not recommended, but when episiotomy is done, it has to be at 60-degree angle when the head is crowning, and application of manual fundal pressure to facilitate childbirth during second stage of labor is not recommended. When such an obstetric practice is followed, we can ensure the quality of life of this woman, which she may develop 20 or 30 years later after her vaginal delivery. And thank you all for the patient listening.